Dear Professor Nair, thank you so much for your outstanding hospitality. And I would like to give my congratulations to Professor Redl. He was my promoter, or thanks for his productive knowledges. I am in the operating room, and today the session is inside of the cell. The orthopedic surgeon do not forget the inside of the orthopedic cell, cell, and we have to be the bridge between the inside of the cell and the operating room. And we are not a technician, but we should not forget the basic science. Now, starting by the hard tissue, then cartilage, and now we are in the soft tissue level. Tendon and ligaments. There are not alone tendon and ligaments. Do not forget the fascia, do not forget the membranes, and do not forget the other tissues. But we know that tendon is the bridge between the bone and the muscle, and the ligaments is the bridge between the bone and the bone. Look at the tendon structure. We are talking about the tendon only, but there are a lot of details inside of the tendon. Peritendinous area, and inside of the area is a big architecture with the bioimmunohistochemical structures. This is the paratenon. This is the epitenon under the paratenon, and this is the endotenon. Endotenon is around all the fibers. This is the paratenon, this is the epitenon, this is the endotenon, this layer, and this is the tertiary fiber bundle, this area, and this is again endotenon. All are plenty of mesenchymal cells, because in every step of our walk or changing the place, all the tendons and ligaments have the injury, depending on the level. But be sure that autobiology can give the pulses or the pressure for spontaneous healing. Look at the normal tendon with the plenty of proteoglycan and plenty of collagen, with the non-problematic tenocyte, but depending on the age, the number of proteoglycan decrease and the number of collagen decrease too, and the shape of the tenocyte change. And at the tendinopathies, according to the inflammatory, the proteoglycan try to push to get the spontaneous healing of the tendon. And you can see the vessels around the tendon, plenty of pericytes. The pericytes are the stimulus of the mesenchymal cells. The chapter of Dr. Ackerman is really fantastic in my book. Thanks to him. At the normal tendon, the flat, elongated tenocytes are regular. In abnormal tendons, increasing in activated cells are very attractive. In normal tendon, parallel collagen fibers, as I showed you before. In the abnormal tendon, loss of collagen architecture and smaller proteoglycan, but in inflamed tendons, increasing of the number and size of the proteoglycans. In the normal tendon, minimal vascularity and nerves, but in the abnormal tendon, increasing in vessels and nerves. As I told you that the vessels, the rete is include of perisides. Perisides are very, very important. On the other side, in the ligaments, the mechanoreceptors are important. And in the tendons, also, the mechanoreceptors are important. Depending on the age, the number of mechanoreceptors decrease, and this is our animal study. But I know that in Italy, I have a lot of friends. For example, Giuliano Cerulli works on this field since, and at the end, 80s. And they said that according to age, the number of the mechanoreceptors decreased. The tendinopathies in sports is very important, and because the overuse injuries and the level of the injuries can change, and overuse injuries is one of the cause of the problems, chronic problems. You can see here initiation of the walking or running style, then after progression of the inflammation, then after you can see here the length and the weight of the tendon is a little bit different if you compare with the proximal side. In my practice, I use my scope, I see the vascularity of the tendon, I make the peignage, not in tendonitis, but in tendinosis mostly. Look at this, this is the tendonitis, sorry. Tendinopathies is the umbrella. Under the umbrella, we can talk about the tendonitis. Tenosynovitis is the paratendonitis, and the tendinosis is the calcification, is the degeneration of the inside of the tendon. Look at the anatomy of the tendon, and there are a pro-collagen just inside of the tendon, and on the other side, you can see different signs of the tendon units and plenty of cross-linking of the proteoglycan can be seen on your left. The structures is the progenitor cells are fibroblast, and plenty of water, type 1 collagen, then other collagen 2 is about 3 and 5%. Elastin is important, but higher in ligaments, about 6 or 7%. Fibronectin, other glycoproteins, and proteoglycans. According to the cellular aspect, fibroblasts are 90-95s, and the tenoblast, tenocyte, and ligamentocyte. Tenocyte are fibroblasts in the tendon, ligamentocyte are fibrocyte in the ligament. On the other hand, in the cartilage, we can talk about the chondrocyte. In the tendon, there is nowadays, or in the literature, they said that there is no vascularity, but I will show at the end the vascularity after the microfracture of the tendon inside of the tendon. And this is the parallel collagen right here, less parallel in ligament, and you can see the random architecture of the collagen on your right. And do not, as I told you in the first slide, that do not forget the fascia. There is no only tendon and ligament. Fascia, superficial fascia, and deep fascia. For example, look at your aponeurosis in your hand. There is a deep fascia and superficial fascia. You can move your fingers with those fascia, gliding according to hyaluronic acid and the other materials. Heat shock proteins 25 and 72. Do not forget this, because in the tendon, the heat position, heating, about more than 45 degrees, making after the exercise of the individual. the temperature more than 45, you can get the heat shock proteins. The heat shock proteins protect the muscles, accordingly protect the tendons against to the injury. This is the heat shock proteins. After the exercise, it's very easy to see the chain and the heat shock proteins come look at these proteins, but do not go inside of sauna. This is one kind of getting the high temperature. You should make the exercise in the field in your life. After you can get the heat shock proteins. You should know the sprain is capsuloligamentous injury. Strain is muscles and tendon injury. There is a difference. And if you talk about the sprain, you should think capsule and ligament. If you talk about strain, you should think tendon and muscle. Biomechanically, fibers parallel to the load axis, low viscoelasticity, and the resistant to strain and tension, linear strain curve, no plastic deformation. If there is a plastic deformation, this is the ligament degeneration start. And this is the ligament relaxation stage. This is the ligament under tension. In the normal position, the isometricity can be seen after the trauma in the ligament. If there is no isometricity, you should think that there is a degeneration of the ligament. Tenocyte is the major cells of the tendon, as I told you. The progenitor cells are fibrocyte, fibroblast. Then arranged in direction of muscle loading arrays, form mature tendon, synthesize type 1, collagen 95%, type 3, and induce assembly of collagen fibers, basic unit of the tendons. There is no big difference between tendon and ligament because we use tendons instead of ligament at the ACL or in the PCL, but we should know that tendon is tendon. There is no ligamentization. Tendon is the scaffold. Around the tendon, you can see the ligament, and we should continue to make some investigation. This is a real ligament or pseudo ligament. But stability is the stability. This is the active tenocyte. This is the type 1. This is the, you can see, inactive tenocyte. The difference of the shape is very, depending on age, also the shape of the tenocyte change. At the cardiomyopathies, you can see the myocytes are the major component. At the bone lesions and disorders, osteoblasts are the major component. At the tendinopathies, tenocyte and ligament injuries, tenocyte and ligamentocyte are the major component. At the osteoarthritis, chondrocytes are the major component. If we make the culture of these cells, is this the real native tissue? I don't know. Because at the animal, we can get some studies, and at the end we can say something about the animals, not the human. After the ACL reconstruction, for example, after 6 months or 1 year of making the second arthroscopy, it's not easy, not ethical nowadays to get the biopsy and say that this is a real ligament or not. The vascularity is the other important point, and the supplementation comes from the synovial tissue and synovial fluid. via perfusion, via muscles, paratenon, mesotenon, vincula, synovial, and periosteal, come all the nutrition cells with the vascularity. Do not forget oxygenation. We talk about the regeneration, we talk about the healing, but if the oxygenation is enough, we can get the healing. For this, soft tissue oxygenation is the major chapter for getting full fracture healing. If there is no healing, thinking around the fractured area, the soft tissue oxygenation is not enough. For this, we have some, we make some measurement of the oxygen volume of the tissue. On the other hand, neural composition is important. Peptidergic nerves, that means substance P fibers, calcitonin gene-related peptide, or the neural composition. There are autonomic system. There are elements of the autonomic system. On the other hand, mechanoreceptor, as you know very well, Golgi apparatus, Pacini, Raffini. What's the origin of Golgi? Filippo. He's from Pavia. Professor in the Pavia University. Volta? Again Pavia. Yeah. Everything is Pavia with Scarpa. Scarpa also is from Pavia. And Cremona is 20 minutes of Pavia, is the major area of violin, Cremona, right? Guarneri, Amati, Stradivari, right? Thank you. Okay, any question until now? Mehmet? Not yet. You have some question? No, from my friend from Italy, yeah. Until now, I understand andiamo. Not andiamo, okay, thank you. The other important point is the tendon, the junction of the tendon bone, ligament bone, tendon, muscle. These areas, we can say that there is some anastomosis in this area. If there is an anastomosis, these lines or these points are weak. But depending on age, these lines come a little bit weak, and some avulsion can be done after depending on the level of the injury in this area. And in our study, multicentric study, at the end we said that, Dr. Ateshok said that the native tendon bone interface exhibit distinct yet continuous tissue regions, including ligament, fibrocartilage, and bone. Meaning this is the ligament or tendon, but fibrocartilage is the tight zone, then cartilage, and the bone. Remember the Sharpie zone. But Pesanserinus, like you know, it's a very, not one point, it's a big point, a big area. For this, the vascularity of this area very important, especially in the child, in the kids. This area important because the metaphyse and metaphysodiaphyseal area and epiphyse. And the vascularity in this area is important. Need to progress the physis line and protect the insertion of the tendon bone and tendon and ligament bone. This is the tendon independent phase, and this is the tendon dependent phase. Here you can see the collagen. Number one, different type of collagen, and this is the this is the tendon or ligament, and this is not a ligament. This is a tendon, and this is the muscle area. Depending on the age, this area, the junction area, can come, as I told you, a little bit weak. Basic function of ligament: limit the joint motion, stabilization, proprioception, and nociception. Nociceptors, including P substance fibers, are in the ligaments with the tendons. But at the tendons, there is a transformation of the muscle load, and with the tendons we can move the tendons are the transmission of the motor activity, but the ligaments are static, give the static stability to the joint. And if you make the difference with tendon and ligament, tendons are more shorter, lower collagen percent, higher of elastin. This is the ligament. Higher of elastin always are ligament, because there is no elasticity of the ligament like tendons. The muscles give the elasticity to the tendons, but there is no a lot elasticity at the ligament. In the ligaments, the collagen fibers are less organized if you compare with the tendons. The healing, as you see here, this is the normal ligament, this is the collagen, but here you can see the bleeding area. With the bleeding area, the growth factor come, and this is after the third week, you can see the refreshment of the collagen. The inflammatory phase is about 1 week. The proliferative phase is about 3 weeks. In this phase, angiogenesis is very important step. Then remodeling is about 1 year, between 1 year and 3 years. Then after maturation phase, but in the kids, in the childhood, this is the same tissue, but in the elderly phase, this is the scar tissue. For this, we try to give some regenerative elements for getting the native tissue mostly in the elderly persons. And on the other hand, the tensile strength and elastic modulus are important point. I'm not a man of the biomechanics, but the posterior bundle of PCL, for example, is about 100 megapascal. Anterolateral bundle of PCL is about 300 megapascal. At the tendon is more less, but in the ligament is more. This is the you can see ligament, and this is the antecipity is just at the attachment of the ligament and the bone. And if the antecipity, if the patient have an antecipity, we should know that rheumatoid arthritis and some collagen disorders can be in this patient. Do not forget that general disorders is the major cause of the antecipity. For example, from my side, Achilles tendon rupture is not a mechanically. This is one kind of tendon pathology. If there is a pathology, if there is a tendinosis, this is one cause of the rupture of the tendon. Because via Achilles tendon, you can pull a car. It's a very strong. But in one position, in the middle of, for example, winter time, the soccer player can get the Achilles tendon rupture without warming up before starting to the playing soccer. Here you can see the native. There is no scar tissue. This is the Achilles tendon. This is the regeneration of the Achilles tendon rupture made in the laboratory. This is the native tendon, Achilles tendon tissue. This is the scar tissue. This is at the adult, and this is at the neonatal period. Because the mesenchymal cells and the other are the promoter for getting the spontaneous healing. This is the Achilles tendon of the bison right here, and this is the Achilles tendon for pushing the animal forward. This is the Edward Muybridge is the first animator at the end of 80s, and I show these slides always because before starting to show Achilles tendon, bisons, 3,000 ton or 2,000 ton, and with a short Achilles tendon, with the short gastrosoleus power, move on. It's very interesting. There is no, I don't know, there is no a lot, I think, Achilles tendon rupture, because nobody play with the Achilles tendon, make some scar tissue promoting medical device or making some injection. Do not use with the cortisone, do not push cortisone inside of any tendon or any ligament. Ligament no, but do not use cortisone. And on the other hand, PRP or PRGF, I prefer to say PRGF because PRGF is, PRP is the umbrella. PRGF is, you have to focus on the PRGF, platelet-rich growth factor. Buffy coat is very thin part. You should be a mosquito for getting the Buffy coat. How many get the Buffy coat? Tolga, you use PRP? You don't believe to PRP? Sometimes. What's the meaning of sometimes? You use PRP or PRGF? And
before PRP, but now I understand that if I will make, I every time choose PRGF.
PRGF, okay.
And especially on tendon and paratendon pathologies. But a lot of times before, a lot of orthopedic surgeons use PRP for joint injuries and joint pathologies. But now, in this year, nowadays, we know this is not very
Effective.
effective thing.
Okay. Okay. How many use PRP? Filippo, you use PRP? Never? Any collect? No? Because to get the Buffy coat is not easy. And I don't believe to this. And this is the paratendon of the Achilles tendon. Look at the... And the rupture is inside of the paratendon. This is the paratendon. Do not forget endothenon and epitenon. Plenty of mesenchymal cell. This is endoscopic view. And in the ACL, there is a very thin cover. Not a synovial like that. But look at the synovia, and this is the same synovia. This is the synovia. This is the fibroblast in the histological view. Fibroblast like synovia site. And this is the synovia of PCL. For this, in the first step, do not touch the PCL. Conservative treatment, I said organic surgery made by the person, by the individual. Because all the cells, pericytes, are the surgeons. try to heal. Coming from synovia, plenty of vessels, you don't see, by microscopy you can see this, and around the pericytes. Because we have 2 or 3 studies published in ESCA journal. We produce cartilage inside of synovia, we produce cartilage inside of the peritoneum. And yes,
Can I ask you said
always,
yes, Professor.
yeah.
You said this for ACL or PCL. I said
This is ACL, this is PCL.
yes, I said ACL. I know like this intra-articular but extra-synovial.
PCL is intraarticular but extrasynovial.
Yes.
ACL is intraarticular, but there is no synovia, there is cover. It's a very thin cover.
Only a thin cover.
Yeah, yeah. And just in the middle of ACL, there is a blood vessel. For this, is there any hemanthrosis after the complete rupture, mid-substance rupture? Yeah, like sciatic nerve. Just inside, in the middle of the sciatic nerve, you can find a vessel. Fibroblast-like synoviocyte. In Florence, in 2008, it was a FORD meeting, and I showed the Achilles tendon paratenon, and Nicola Mafulli, good friend of me, said, and I said that this is a synovia or Achilles tendon, and he said that there is no synovia in Achilles tendon. I said yes, and nowadays I have a lot of histologic view that this is the fibroblast like synoviocyte. Plenty of mesenchymal cells. Okay, today ACL is more than 1.5 billion cost with the revision, but I believe, this is my motto, there is no only ACL in the knee joint, in the fresh time, in the early time of the injury. If you do your surgery, your organic surgery, if you regenerate the ruptured ACL, you can get spontaneous healing in 6 weeks, not biomechanically, only the tissue. In 1992, hyaluronic acid injected inside of the knee joint of the rat or in animals after cutting the ACL, they find the same. In the first 3 months, if you put your scope inside of the knee joint at the ACL rupture, I don't believe to the MRI, I believe to my hands and pivot shift test in external rotation and internal rotation. If I see full rupture with the ruptured end, proximal side and distal side, I make intraligamentous splintage. Nowadays, Arthrex get a lot of money with this. I use this about years and years, not in all the cases. My Achilles tendon technique is the same. MCL is the same. MPFL is the same. It's easy because do not touch the isometric point. If you send, I use PDS, 10 euros or I don't know how, but not much more than 15 euros, 1.5. Not 1,500 the cost. Because Arthrex sells about 1,000, something like that. Single bundle. Years and years, when I was in Zarlui working with Professor Hess, they use PDS bundles and cordel. Nowadays, I don't know, I don't see, but PDS double loop, that's enough, number 2. But you should know the topographic line of the ligament. For this, there is no only ACL in the knee joint. If there is a rupture, you have to repair, not repair, reinforced by PDS intraligamentous. Then checking the other corners, posterolateral, posteromedial, MCL, LCL, because there is no only ACL. Always I protect the distal part mostly right here. It's not easy to go inside and protect, but about more than 10 years I protect the distal part. Started with Mitsuyo Ochi. This is an allograft after 1 year. Not in all cases. This is a beautiful case, can I show you? Because I have some rupture too. But ligament, this is a tendon, a round ligament, and tendon was a scaffold, inside tendon, a round ligament, but never made any biopsy. Because you can get some punch biopsy. You have to make like a prostate biopsy, more than 20. If you do more than 20 biopsies, you can make the reconstruction of the reconstructed ACL. If the person, the individual, accept to give his body at the end of his life, but it's not easy to find this kind of persons. Okay. This is hyaluronic patch. Hyaluronic. And I put some hyalofast too. This is not a place for using this. We use this for the cartilage defect. But I have full healing. I have more than 5 now, without any symptoms. And do not forget spontaneous healing in the early time of the ACL ruptures. Do not abuse your surgery because you are in your first level of your surgical life, and believe to the organic healing. All the cells are the organic surgeons of the 7.5 billion individual in this planet. And PRGF. Okay. The vascularity of the Achilles tendon, respect to Pau Golano. He sent me, he wrote for my book. This is extraordinary, fresh cadaver view. Believe that in each individual, both Achilles tendon vessels, structures are different. There is no, do not make any vascular pathway of the Achilles tendon. You can find 7.4 billion in this planet, different. The vascularity is important. Okay, sorry. The vascularity of the Palatinum is important. For this, in every, about more than 10 years, I use my scope for making intratendinous splintage of the Achilles tendon ruptures. But the vascularity is important because at the end you can return to play, to continue to make a sports after 6 months, 7 months, or 5 months. There is no big difference if you open, but if there is a infection, is a big problem after the big incisions. Okay, this is the, I put my PDS inside of the tendon, inside of the ligaments. This is the around the joint, outside of the ligament, outside of the tendon, reinforcement, splintage. And if there is a rupture of the tendon, this is one of the biggest in the human body, Achilles tendon. Achilles tendon rupture with non-rupture of the paratendon. For this 30%, 20 or 30 years ago, there were some publications coming from the Scandinavian countries, conservative treatment, and they said 30% full healing. And I believe that these patients had a torn Achilles tendon with intact or nothing around the Achilles tendon. That's mean intact paratendon. You can give the moon boat, you can inject PRGF. After 2 months, you will see full healing. But, sorry?
I think similar.
Similar or the same? You think? You don't think the same? Similar.
Because a lot of important thing is paratendon.
If there is no problem in the paratendon, look at this is the paratendon intact because I find the ruptured area when I put my probe inside of the paratendon and I find at the end. You can do conservative treatment, but impossible to see with the MRI view. For this I use my scope. And local anesthesia, infiltrative anesthesia, no tourniquet with collaboration, correlation, communication with the patient, and day case mostly, but 1 night rest, no problem. And this is the ruptured paratendon with ruptured Achilles tendon. In this case, I do my splintage inside of the tendon. Look for the future, but be careful. The other come from your front. Big respect to Jules Verne, because he is a thinker. And do not forget, Einstein said, I want to see mostly the thinkers, not the scientists. Thinker and scientist at the same time, big respect. But first you have to, you should be an inventor. The baby is an inventor. I was a baby because I find my nose, my tongue, my eyes. To be an inventor is different. Edison, General Electric, all the motors of the aviation system come from the Edison. He was an inventor, and Tesla too. But Tesla was a mostly scientist. He was a poor. Okay, this is the, I think, chef-d'oeuvre, master of the life. Coagulum. Plenty of growth hormone. Growth factor, sorry. But we don't know which one. Okay, it's very classical. Very classical at the same time. And the quality of the tendons and the quality of the ligaments, depending on your gene, depending on your genetic knowledge is coming from your back, and blood group O. One group make this with Mafuli and Magra said that Hungarian Finnish, meaning Turkish. The Turks are the same line. We are more, we have a risk of tendinopathies. I don't know. I would like to say my last phrase, and chromosome surgery under the microscopy, with the microscopy, will be the more popular in the next maybe 25 years. Because you can get the quality of your tendons, muscles, ligaments with before in the neonatal time. Then if you can change via some manipulation, you can get a correct, good quality. Because I know 90 years old continue to play tennis with a good cartilage via MRI view. I don't understand. Aging is not real. The quality of the genes are important. For this, genes meaning chromosome, DNA, RNA, messenger RNA, and all the amino acids, etc. And if we can manipulate adenosine, cytosine, guanine, thymine, via knife, the micro knife, we can get something. Okay, again, big respect to Jules Verne. Waiting all of you to APOA, because in this region, and there will be the President of the Congress, Dr. Ner, and this region is the population in this region is very high. So India and Korea and Japan and China, they use dollars, not euro. Okay, thank you for your attention.